streaming live panel discussion. You know, my name is Patrick Canty. Get this kicked off, and my day job is publisher of the Odessa American. And I've had the wonderful opportunity to be a part of this series that's been brought to us by Ravi Shakamuri and Star Hospice. As I mentioned earlier, this is our eighth streaming program. The previous seven have all dealt with various aspects of the COVID-19 pandemic. And we did a great job fleshing that out. And so we decided, you know what, let's broaden this and talk about other areas of medicine. And that's the beauty of this whole program, I think, is that we get to talk and visit with real doctors, real healthcare professionals, and get to learn something more about these various fields. And tonight, what we're going to do is we're going to talk about advances in heart care. And there have been so many. And to help us discuss, flesh that out is actually a hometown Odessa native, Dr. Adam Farber. And Dr. Farber was a graduate of 2003 of Permian High School. And then he went on to UTPB, University of Texas Permian Basin, for pre-med, correct, doctor? And then from there, went to medical school at UT Medical Branch in Galveston. And then he did 3 training programs at Baylor Scott and White in Temple, Texas, before returning back to Odessa, where he's been practicing now board certified internal medicine, cardiovascular disease, and interventional cardiology. So we are so glad to have you here tonight. We're glad that you just chose to come home to Odessa to care for us. So welcome. Glad you're here tonight, Dr. Farber.
Yeah. Thank you very much.
So what we may have also joining us later, this is the issue we got with doctors. When you got doctors, things happen. So we have Dr. Fernando Bocalandro. He may be joining us later, but he's been held up at the hospital, which is not uncommon. So if he shows up, we'll add him to the conversation. But for now, what we'd like to do is kind of kick this off by, I guess, I'll tee this up by saying, you know, if I had a heart condition 20, 30 years ago, I'd be looking at very different prospects of treatment and outcomes. And if you could kind of help us kind of put that in perspective as to how far we've come, not only in the last 20 years, but maybe in the last 5 or 10.
Yeah, I think it's been an escalating acceleration of not only growth in cardiovascular care, but the technology and just our ability to treat heart conditions. Unfortunately, heart disease has demanded this, particularly in the United States and in the first world. It's a primary cause of death in this country on most years. I actually don't know whether that's going to be true in the immediate past with COVID, but I imagine it still is. And it has been the primary cause of death in the US for many, many years, I believe decades. And so that it has driven both medicine and the industry that supports medicine to innovate in cardiovascular care. So if you want to talk about a timeline of 20 or 30 years, it is a completely different landscape.
Yeah.
Absolutely. Like the expectations of patients who have had heart attacks, even in the 80s, were completely different. And we know that they didn't get treated in a similar manner. And so that has really led to progressive technologies and really treating people who have blood flow problems to the heart, people who have weak hearts, people who have electrical problems with the heart, and more recently, people who have structural problems with the heart that have problems with either the valves or how the heart is shaped. And within the last 10 to 15 years, there's been a lot of innovation and employment of devices that can treat these diseases without having to open the chest and cut out the diseased parts and sewing everything together. So it makes a tremendous difference for many patients.
Yeah, that's a great point, because I'm amazed to hear of some of these new techniques, and they're not invasive. And I remember it wasn't that long ago. It was around 2003 where they were talking about the Da Vinci, you know, the robotic surgery on hearts, and it was a big thing here in Odessa. You know, that was when Alliance Hospital, which was now part of ORMC, and they were doing robotics, and and everyone thought that was just earth shattering. But now, I mean, that's like, that's kind of routine. And as you mentioned, now there are all these treatments that are non-invasive. Talk about some of those that are really kind of becoming much more commonplace.
Yeah. So as far as more commonplace, probably the most accepted, most thorough one that has proven benefit is TAVR. We call it TAVR or TAVI, transcatheter aortic valve implantation, and this is a procedure that treats heart valves that are calcified and stiff and don't open enough. And when they do, it's basically a one-way valve, and usually it opens nicely and then closes nicely, so it doesn't leak backwards and it lets blood flow out of the heart to the body just fine. But when this valve is diseased, and it can be diseased for a number of reasons, but the most common reason is just simply age, it becomes more calcified and stiff, then the heart has to work very hard to squeeze all the blood through a very small hole. And the way that this has been treated for decades, since they started, open heart surgery, was to actually open the chest, cut the valve out, and put in a prosthetic valve of some sort.
Right.
And initially, most of these were mechanical valves, but then what we call bioprosthetic valves, where they're a mixture of tissue, animal tissue, and an appropriately shaped prosthetic material, have developed over the last few decades. Well, they have great outcomes in the right patients, and they prolong patients' lives extensively. Patients who have aortic valve, we call aortic valve stenosis. Patients who have that disease, they do not do well once it becomes severe. Once they start to develop symptoms, they die at very high rates within the first 1 to 2 years. Okay?
Because it's so far advanced by the time the symptoms show up, is that?
Well, it does, and it's a slow advancing disease process, but there's kind of a narrow window of when we try to fix these. When patients develop symptoms, but usually before they start to decompensate, before their heart becomes weak. Patients who suffer from these kind of valves, they actually slow down kind of slowly over a period of years. And sometimes their symptoms are not so dramatic. Sometimes they are. Sometimes they develop chest pain. Sometimes they start passing out, or their heart just gets weak. And when you have to very quickly identify who is at risk of doing that. And we have certain criteria that we know who is at risk, but patients don't always get monitored. Patients don't always come in.
Right.
And so, sometimes we find them too late. But I guess kind of the topic of the night is those patients sometimes are 80, 90 years old, sometimes older than that. And going through an open heart surgery at that age is complicated for a healthy person. Okay. And then you take a person who has other, what we call comorbidities, or other things that make them unhealthy. It could be a variety of things, right? Common things are a weak heart, bad lungs, bad kidneys. Okay. And when you do that to them, they don't recover as well. And so there's been a huge drive, and I think a huge like an opportunity that was capitalized on, not by the industry, but by patients and physicians, to treat those patients without having to cut their chest open. Okay. And so that's what TAVR is. So we implant a valve by going in through usually an artery in the leg. We don't ever have to cut the chest open at all. And it's a smaller incision, about smaller than most people's pinky finger, the fifth finger. And we're able to do that. Actually, it's been refined, and we're on multiple generations of the devices. The techniques have really been refined in how we do this. And so that these patients, we don't even put them all to sleep. You don't even have to go fully to sleep. We just give you a little medication that keeps you relaxed. And while we do it, it's all preparation,
right? Getting
planned, and we have to make a map of everything, and you just get it in place, and then it usually doesn't take but a few minutes to deploy it. And when we do that, it's assuming things go well, just do very, very well.
So it's kind of like going into having a stent put in.
It actually is extraordinarily similar to that, but a big stent.
So describe the device itself. Is it like a little valve that's electronically controlled, or like a pacemaker?
No, so there's 3 different devices that are FDA approved, 2 of them that are commonly used. They both have a metal scaffold, and The metal is kind of a cross weave, and it's shaped into a cylinder. And then within that, they tie in bioprosthetic material. It's either from it's bovine or porcine, a pig or a cow.
Okay.
And it's cut and sewn in such a way that it actually creates a one-way valve, like almost like an inverted parachute kind of thing.
Right.
To where they open up when the blood flows through, and then when it tries to go backwards, they against each other.
Good.
And so one of those we actually implant by expanding with a balloon, and the other one is a metal that has memory to it, and it actually opens up itself. You just put it in the right place and let it go in a very controlled fashion, and it just expands and pushes away all the other calcium that's in the way, and just kind of moves it to the side. And so the new valve is left behind, and it's just a metal scaffold with the tissue leaflets, we call them, inside of it.
So where does that go in relation to the valve that's, to the defective valve?
Yes, sir. So the defective valve will have a hole in it, and we go inside that hole.
Okay.
And oftentimes that calcium is so tough and so tight, we actually have to use a balloon to expand that calcium.
Okay.
And then when you put the device inside of it and then expand it, it literally goes right inside the old valve and pushes the old valve out to the side. So the old valve that's calcified is actually what we use to anchor the new valve so that it doesn't slip out. Yeah, there's no suturing or clips or anything. It's completely mechanical. It is not active. There's no battery to it.
Right.
It just works by its structure and
So this is the solution to either going in through the side or cracking the chest and installing a pig valve, or
yes, sir. Yeah.
So what has been the timeline? Because I remember my dad going up to the Mayo and having a valve replacement, 7 years ago. So this is something that's just really come online, last 5 or 6 years?
So this valve was first developed and employed in Europe. Europe's a little more, I'd say, liberal with these things in the non-political sense. And the FDA, I'm quite sure, approved it in 2011. The first generation device on certain subpatients was approved in 2011. And these were patients that we call prohibitive risk, patients that we knew you're not going to survive an open heart surgery.
Right.
The first generation devices, they have certain limitations. And so we're kind of on the third generation of devices now, and it's amazing how much difference it makes. The techniques have improved a lot. And between the two of those things, since 2011, we've actually been able to study the valve, and the medical community has been able to study the valve in different populations. And so now it's approved, and we know that it actually benefits patients who are not only prohibitive risk, right, but patients who are even as what we call low risk. Okay, so this is younger and younger patients. So there are 60 and 70-year-olds who have this kind of disease, right? And some of them, it's appropriate to still do heart surgery, but a lot of them, we've shown that they can benefit tremendously from these valves. And if given the choice, a lot of patients will pick to have this kind of valve for sure.
Well, and I guess if you have issues, is it easier to go back in and deal with that issue with that valve than to crack them open again? And
right. So when you put these valves in, it's kind of a whole different set of issues. Most actually surgical valves perform very well. When you put a valve in with surgery, they perform very well. Okay, we know what they do. We know how long they last. Mechanical valves that are they don't have any prosthetic tissue or leaflet kind of material. They're actually usually like a metal flap. Okay, those last decades, like decades and decades. I mean, they can last a long time. Okay,
right.
But you have to take blood thinners with those. All right. So the mechanical valves you have to take a blood thinner with, and that gets complicated in old people. Okay, older people. So the other type of valve is a bioprosthetic valve, and the advantage of that one is you don't have to take a blood thinner. And so the main complication with putting that valve in is actually healing from the surgery for the most part. Okay, it's not with the valve itself. With the new valves, the TAVR or TAVI valves, those valves tend to have a different set of complications. It's a little bit higher pacemaker rate. And one of the things that we are going to learn is how long they last. If we just started implanting them in 2011, we're kind of coming up on 10 years. Not that many of them were implanted the first few years, right? And so by the time you get to a third generation device and they're being widespread implanted, it may be another 5 to 10 years before we really know how long do they last. And that can be a big question because you talk about repeat procedures. And so, but there's a strong argument, would you rather have a procedure where we go in your leg and you don't have any complications and you're in the hospital one day? Would you rather have that twice in your life?
Yeah.
Yeah. Or would you like to have just one big surgery? And certain patients require one valve over the other.
Right.
And that's where definitely you need to have a discussion with your doctors. But
so how, talk about, okay, how many of these have y'all been doing in Odessa, Midland, Odessa area?
So in Midland, Odessa, so we started the program here in Odessa in the fall of 2019. And I think we are almost to 40 valves. I think it's either 38 or 39 valves here so far.
Wow.
Which is pretty appropriate considering the historical numbers of how many people require this kind of surgery.
Mm-hmm.
But not all of them are being done here. So there are still patients who need this. And we're a center who we do have good experience, and there's a large group of these patients who we can do here and we can do safely. But part of doing this safely and part of truly making the best choice for a patient is the ones who are really high risk. We send them to programs that do hundreds of these a year. Okay. And so and this is kind of as in most parts of the world, it's a very small world. It's a very small group of people who do this kind of thing.
Sure.
Right. And so we've made connections over the years, and we know people who we trust to do these when they are very high risk.
Mm-hmm.
And so every now and then we do have to find one, and we find one that we have to send out.
But and maybe now's a good time to talk about this. I think there's still a lot of people out there that live in Odessa, for example, and they think, well, if I have a heart condition, I've got to go to a place like Dallas or the Mayo or Houston, but we really do have a pretty robust kind of menu of cardiology services here, don't we?
There's no doubt. This, I think the reason that this technology has not existed here before is simply there's not that much movement of doctors who are recently trained into West Texas.
Mm-hmm.
Okay. Many cardiologists who have been trained in the last 5 years do this procedure, but not many of them end up out here. Right. And so it's just a factor of that. And so when you finally, I've been trained in this, we come out here, it takes a little while to get the support of, the whole hospital, the whole medical community. I mean, there's a lot of people that, they've seen this, they have a few patients that float around, that they're out here. Yeah, it can be done. But, it takes a little while to inspire confidence in a doctor to send his patient that he's taken care of for 20 years to you. Right. So those things have taken time to through with the hospital and with my partners and with all the physicians around, honestly. And that is one of the reasons we focus on trying to have excellent outcomes out here. Because when you have a center where we don't do hundreds of these a year, you have to do a good job, and that means you have to do ones that will be appropriate. And so if they're high risk or there's something complicated, sometimes we do send those patients out. But having that service here in West Texas has been great for the hospital. It's been great for the medical community. And really, I think it's a big benefit to the patients because a lot of these patients, they have a hard time traveling.
Right.
And taking their family, because you're going to be recovering for who knows how long in another hospital. And these things, even if the procedure is only a day, you're going to spend 3 or 4 days there minimum, right? Mm-hmm. That's not always easy for patients and their families.
Right. So talk about the training that you had to go through to perform this. I mean, I'm sure it's more than just a weekend at the DFW Marriott, the conference room. It's probably pretty extensive. Tell us about some of that.
Yeah, there are technical measures that you have to meet, both with the companies who make these valves, so they regulate who puts their valves in, but also by like CMS and the the hospital itself, like they establish guidelines to say, well, we think you can do this because you have this experience, right? So yeah, so not everybody, but most people actually go through a formal training program. You know, in my training at Scott and White is 3 years of internal medicine. And only at that point, after those 3 years, which are after medical school, you do 3 years of cardiology. And none of that do I get to do this procedure, right? Only after that, when you do interventional cardiology training, do you get experience with this kind of procedure. And so I was an interventional cardiology fellow for 1 year. And that's pretty typical. Sometimes there's 2-year programs if they're split up into different stuff. But for that 1 year, I did 102 of these valves. So I would basically do one every 3 days,
Wow.
you know, approximately. And you know, we kind of group them up and whatnot. So, and then my partner who I was training with also got that same volume. And so we would see these together. So we saw large volume cases. We saw over 200 cases personally and did, you know, were involved in half of those, and then probably a total of a quarter of them, you know, we actually do ourselves. And so our training is extensive. And what's really nice about that is, especially training at a high volume center, you get to see the complicated ones. You get to see the ones that don't go so well, so you know when to stay out of trouble, right? And so
that's pretty.
Training.
So, you know, these kinds of things obviously help save lives for people with heart conditions. But I got a great question or observation. Dr. Anand Reddy, who's, you know, one of our more prominent kidney doctors in the area, and he just, you know, texted in saying that these kind of procedures are really a blessing to a lot of his high risk patients on dialysis. So talk a little bit about that, because it's not just about the heart. The heart, you know, interacts with so many other things, and it can really help conditions, you know, other types of conditions.
Yeah, absolutely. And so this kind of leads into, we were talking about what patients, you know, patients who have to have open heart surgery, what other problems do they have that make that high risk, right? Kidney problems are one of those major features. Okay. Now you can really injure the kidneys when you go through open heart surgery for a number of reasons, of which Anand Reddy would be the professional and the guy to ask about those things, right? But we watch and we all see, we take care of these patients together seriously, pretty much every day. And so the ability to not injure the kidneys with a large challenge or a big insult to the body can prevent patients from having worse outcomes with their kidneys. Okay. And that's not even kind of addressing this issue of when you have a bad valve, if you don't treat it and the heart becomes weak, as soon as the heart quits pumping blood efficiently and you start building up fluid in the body, the kidneys do not do well. Right. The kidneys have to have really good blood flow. And that goes for, you know, a lot of the other organs, okay, for sure. And so when you have advancing heart failure to where the heart is starting to not pump very well, and that can happen just because of this valve, in addition to other problems, particularly patients with, you know, chronic kidney disease, chronic liver disease, those kind of things, you can really dig into a hole real fast. And it is hard to get these patients with aortic stenosis. Once they get sick, they are hard to recover. Right. The heart only has so much reserve, and it is a challenge to recover them. So it really is about preventing them.
Just kind of a domino effect.
Yeah.
Yeah. It's so we've talked about TAV. I know there's another procedure called Watchman.
Yes, sir.
So help us understand what Watchman's all about.
Yeah, what so Watchman is our newest addition of tools out here, and Dr. Manohar Angarakula, and myself have started this one. We actually did our first 4 procedures kind of at the end of 2020, and you know, we've been riding the wave of COVID. We don't control everything like we would love to. Okay, but you know, we have to adjust what we do, and Watchman is a procedure where we're elected that we just did them again this year. Watchman is it's really a brand name, and it may be faux pas to use it, but it's so much simpler than the real name. But it is a device that we put into the heart for people who have difficulty with blood thinners and have a condition called atrial fibrillation. The actual name of this procedure is called the left atrial appendage occlusion.
Occlusion. Okay.
It's kind of a mouthful that doesn't mean a lot to people who are not working on hearts frequently. So we just call it Watchman.
Right.
But what it does is it addresses a problem that is quite common. So atrial fibrillation is a heart rhythm problem that usually originates from the top chambers of the heart. And it results in patients having a risk of having a stroke. And so because those blood clots can form from AFib, we put patients on blood thinners to prevent the blood clot from forming. Now, when we do that, we lower their risk of having a stroke down dramatically, almost to a normal person's risk of having a stroke. Everybody's at some risk of having a stroke when you look at a population, as a whole. There's a basal rate of how many people are going to have a stroke, and everybody who has, high blood pressure or diabetes or smoker, like every little thing that you add on is a higher risk of stroke, right? Well, when you have atrial fibrillation, it's the same kind of escalating scale. Well, what blood thinners do is bring that down to very close to what your normal rate of having strokes would be. They're not perfect, but they're really good. Especially nowadays, we have newer blood thinners that are very good. But there is a subset of the population of patients who do not tolerate blood thinners. Patients who have bleeding in their brain, bleeding in their eyeballs, bleeding in their guts, where they lose it in their GI tract. Right. And those patients are intolerant of blood thinners. Sometimes they're at risk of dying. Sometimes they have major complications, even though maybe they're not at risk of dying. And there's a lot of people who take blood thinners who maybe have not had a major bleeding problem yet, but are at risk of it. Yeah. Or just have some other contraindication to a blood thinner. Some people have conditions of the body where they may not need to be on a blood thinner. And so what Watchman does is it's a device that's implanted in that left atrial appendage. And it actually, when we put it in there, we leave it in for about 45 days, and sometimes it requires a little longer, but it heals in place, and it actually occludes or separates or isolates that part of the heart where most of these blood clots form. So about 90% of blood clots that form from atrial fibrillation, we think they come from the left atrial appendage. And so for patients who can't take a blood thinner to prevent a stroke, we can put this device in, and once it heals in place, they can come off of their strong blood thinners and usually just end up on an aspirin.
Okay, that's pretty good.
Yes.
So we have Dr. Fernando Bocolandro has joined us. Welcome, doctor. We're glad you made it. We know you've been busy.
Thank you for the invite.
Oh, well, we're glad you're here. Real quick, tell us, you've been here you almost qualify as an Odessa native. So you came to us from originally Venezuela, correct?
Yes, that's correct. Yeah, I have been here already for 17 years, so it's a long time. Yes. And
you've also had the opportunity to work with TAV and Watchman too, correct?
Yes, I have. I think we all try to do those structural procedures joined together. I think it's Dr. Farber definitely leading the TAVR side, and Dr. Farber and Dr. Angarkula are doing the Watchman. So I think it's a great technology to have locally, and we are very appreciative of their motivation and capacity to do that locally.
Well, I guess my question is, because atrial fibrillation is so common now. You hear about it all the time. I mean, Lord knows you watch TV and there's all sorts of commercials on pharmaceuticals to address it. Is it something that's become more common because of lifestyles leading to more heart conditions, or is it one of those things like sleep apnea? It's become more common because you're able to diagnose it more accurately now.
Right. So I think that's a great point, right? So atrial fibrillation right now is basically epidemic. I mean, the numbers of atrial fibrillation are skyrocketing, and that has to do basically with two factors. The first factor is that people are getting older, thanks to the fact that now we're treating them with different medications and revascularization, so they can live longer with heart disease, which prone them to also have more atrial fibrillation. And also the epidemic that we see was obesity. So atrial fibrillation is very, very related to body weight. So I think those two factors really raise, the incidence or the frequency that we see atrial fibrillation. And also now we start to see the ability to detect atrial fibrillation also is increasing substantially with new technology like Apple Watch and, wearable devices that allow people to detect atrial fibrillation early. And we have technology at home that we can use, like Holter monitor for a certain period of time. So the ability to detect atrial fibrillation also has increased. So the combination of better detection and people that have higher incidence of atrial fibrillation has translated in an epidemic effect of atrial fibrillation we see every day.
Okay. So help us understand, both of you jump in on this. Everyone knows that they call high blood pressure the silent killer because, you could have it and you don't notice any symptoms until, it's too late. What about atrial fibrillation? Is it similar, or are there symptoms that people can kind of be on the lookout for that says, I might need to go see a cardiologist?
Yeah, so as I say, it's important to recognize that 30% of patients with atrial fibrillation are actually asymptomatic.
Okay.
But the majority of them at some point develop symptoms. So, but you have a good number of patients that may be completely asymptomatic and they have a significant risk of a stroke. So an easy way to know about atrial fibrillation is just to check something as easy as the pulse rate.
Okay.
If the pulse rate tends to be low and your resting pulse is low, less likelihood to have atrial fibrillation.
So if you're resting and you have a high pulse rate, that's something that says, hey, wait a minute. What other types, are there any other type of things that say, Joe pedestrian like me should look for, things like ringing in the ears or lightheadedness or any.
Right. So frequent symptoms from atrial fibrillation are palpitations, the heart feels irregular. People can have decrease in functional capacity, for example, shortness of breath or breathlessness when they do activity. So those symptoms are very frequent with atrial fibrillation.
Okay. Dr. Farber, anything to add on that? Or?
Absolutely right on it. The sense of palpitations or just the heart beating funny. Many patients, that's the first time they ever notice that and an elevated heart rate. And sometimes it's when they're doing things that normally they feel fine, and then all of a sudden they're just much more tired or fatigued, and they're not used to that. Sometimes we have patients actually present with a little bit of heart failure already, and they're just starting to swell up and have swelling in the legs even, or they can't breathe when they lay down to sleep.
Right.
Those things sometimes can be triggers for which we find it.
So help us understand. So, when I go in for a TAV, okay, you went over kind of what the procedure is for that. Walk us through the procedure for Watchman, and is it kind of an outpatient, what are we looking at, recovery time? Kind of walk us through what that looks like.
So a Watchman procedure is an elective procedure. This is never an emergency procedure that has to be done, immediately. This is a procedure where we have to plan out a fair amount. Usually, we will do an ultrasound. We call it a TEE, or transesophageal echocardiogram, where we put a patient and get them nice and sleepy and actually put a camera down their throat, like having a scope, like a GI scope, and take pictures of the heart to make sure they have appropriate anatomy. And then we come back on a different day, and it's simply a day procedure. The procedure itself will usually take an hour, maybe 2 hours. But the preparation, again, is the main one, right? So they have to be put to sleep completely. And so it is, I would say from a patient experience, it's probably more like a minor surgery. They will actually go in to the cath lab. They'll come in the morning, usually go into the cath lab, they'll be put to sleep, and then they will wake up the same day. It usually is not going to be very painful. There's a very small incision in the leg, and that's where we put our delivery system up through. And after that, they're taken off the breathing machine, and we will monitor these patients in the hospital, usually just one night. And they'll be able to go home the next day. This small incision actually goes in through a vein, not an artery, which really helps decrease the amount of time that our patients have to be cautious or be restricted. Most of these patients will be up and walking the next day, kind of doing normal stuff around the house. We'll probably tell them to not, go carry things or take out the trash and stuff like that for a few days. But within a week, they will go back to a completely normal life.
Okay. So here's a question from Dr. Jayaram Naidu. Okay, we're going to start throwing the what ifs at you guys.
Oh, yeah.
And Dr. Naidu says, okay, 78-year-old had an ablation, hypertension on Eliquis, had proximal fib. Do I need Watchman?
So it is a possibility. Some patients there's some patients who do need it, right? Who need to be off a blood thinner. And there are some patients who are at risk of having bleeding. And it sounds like this patient may fit in that a little bit more. They may be a viable candidate for Watchman. It kind of depends on some of the other risk factors and risk factors, not only for bleeding, but the risk factors for stroke, which we calculate when we discuss the details with our patients. Okay. But yes, particularly once you start getting older like that, I think he said 78 years old, need may not be quite the right word, but it is a viable candidate. And could they benefit from it? Possibly.
Okay. Now, are there multiple generation devices? Are we that far along with this to where there's a new generation of Watchmen?
Just recently, the second generation. So there's only one company that has an FDA approved device to do this. There are some investigational devices that are being used, but those are of course not widely available. But the second generation device has a better safety profile when it's implanted. It basically is a more gentler device that achieves the same goal, and it has less complications by our evidence so far. So it's kind of the second generation device, to answer your question simply.
Okay, and Dr. Naidu has one follow-up. He says, what's the cost of TAV compared to with minimal invasive surgical replacement? Is it much more cost effective, you think, or?
I don't know an accurate answer to that, okay, because I actually don't know what the insurances bill frequently. I don't deal with that side of this question. But I do know insurances and Medicare do reimburse and pay for these things. Yes. And Dr. Bablando, do you have any insight there? Do you know?
I really don't know exactly what the alternative will cost, right? So I don't know. Yes, that's a good question.
It's a very good question. So
I think this is so new. I think that's what really kind of blows my mind. Is the advancements and how rapid these things have come down. I mean, what about are there medications? The patient that gets Watchman, you're saying basically then maybe an aspirin and that's it. And also, one question I have is after the implant, can they have things like MRIs? Are there complications with having MRIs or setting off medical detectors, things like that, kind of day in, day out things?
Yes, sir. So very good. So the end goal there after the device heals is to be on an aspirin only. That's usually achieved in about 95% of people who have the implant. So not everybody who has the implant gets off of a blood thinner, but it's about 95%, which is actually a pretty good success rate. And so yes, they just end up on an aspirin. The second question, can you have other medical studies, MRIs, CAT scans? Yes is the answer. I will tell you, the terminology they use is called MRI conditional. And you can usually do MRIs of things not directly of the heart, like an MRI of the brain, MRI of the hips, MRI of the knees, and they have to have certain settings on the MRI machine. So we call it MRI conditional, and those are published. We can communicate those. Usually you can find an MRI machine that fits those. Not every facility has every MRI machine. So usually we can find somebody to do that. It can be a frustrating process for both physicians and patients, but yes, it does not prevent people from having MRIs. And as far as metal detectors, no, I don't think they set off metal detectors.
Okay, and Dr. Reddy wants to know, is there, he's asking about the comparison of morbidity between the surgery and TAV versus TAV. What's the comparison there? Is it about the same?
Did you say morbidity? Is that what you said?
Yeah. Is morbidity the same with surgery versus TAV?
Yeah, I think just to clarify that a little bit, the reason I asked about morbidity, there's morbidity and then there's mortality, right? And morbidity is kind of how much you harm somebody, right? Not how many people die from something.
Right.
And so the morbidity with TAVR or TAVI is much less, much less. Okay, for patients, they experience far less harm in numerous ways.
Right.
There is a reduction in mortality for certain groups of patients. Certainly those patients who are at higher risk of surgery and then probably moderate risk as well. TAVR is superior in many of those patients compared to an open heart surgery. But in low risk patients, I cannot tell you that it is superior yet, okay? There are certain patients who are low risk for surgery, we do not expect to have a bad outcome from surgery. If we put TAVR in those patients, there still may be a slight advantage to surgery, and the studies are still going on to where we're teasing that out. And so this is where you take all the factors of a patient's health into consideration in making that choice.
Right. Dr. Bocalandro, I'd love to hear your perspective on, we kind of, Dr. Farber and I kind of started out talking about this, about just, the cardiology landscape now is so different than it was even 10, 20 years ago, the advancements that have been coming down. I'd love to hear your perspective, because I mean, you've been at it, you've been here for 17 years and you've been at it a lot longer. What is your perspective on that? Just all these different improvements that have been coming down. How much has it changed not only the lives of patients that you treat, but your options as a physician too?
Right. Yeah. So I think the progression that you have seen in cardiology over the past decade or perhaps 20 years, right, is really a fascinating story, because what you see is initially cardiologists were focused only on the heart, right? And initially the options that we have to treat those patients for the heart were exclusively related to medications, right? And then we start to understand much better the process of heart disease and of atherosclerosis. And then that concept of heart disease start to expand to a very different arena, which is the cardiovascular arena, right? So now we start to expand our knowledge to not only the heart, but also, what it is, the cardiovascular side, like stroke or aneurysms or peripheral arterial disease. So throughout the years, right, the technology have allowed the cardiovascular, field to expand tremendously now to multiple areas, including electrophysiology, right, for arrhythmias and ablation. Now, what we have been talking tonight, which is structural heart disease, right, like TAVR or Watchman. Also in imaging, the cardiovascular arena have expanded substantially to try to understand better disease pathology and also try to identify subset of patients that are high risk for cardiovascular diseases. And also the part of heart failure, right? Now we have left ventricular assist devices, we have ECMO equipment, we have much better outcome in heart transplantation, right? So what that translates, right? We have new lipid lowering therapy that are magnificent, lowering the cholesterol. So really what that really results is that we have, as you mentioned, so many more options for our patients, which in the past were not available, that really is a tremendous development that have been incredible, the opportunity that we have now to take care for our patients.
I'd like to just point out.
Go ahead.
Just one thing before we move on. In addition to those things, particularly Dr. Bocalandro talks about heart failure, and it may be considered a little bit more boring, but our medical therapy, the drugs that we have, the medications that are pills that we can take at home for patients with heart failure are essentially being revolutionized within the last few years. There's complications with cost of these medications for many of our patients that have heart failure, but they're proving to be extremely effective for patients with heart failure. And I do think that's something that is worth bringing up for sure.
Yeah. I mean, touching in that angle, Dr. Farber mentioned, I think just to give you a statistic, right? Back in the 80s, the mortality of heart failure was actually worse than lymphoma or breast cancer, with a mortality about 50% in 5 years, with people that have a weakened heart. With the current regimen, with the current, revolutionary medication that we have that Dr. Farber alluded to, now we can bring that mortality in 5 years to close to 5%. So we have been able to substantially improve the outcome and not only the outcome, but also the quality of life of this patient. So that has been a fascinating journey.
Yeah, you're talking about when Tav with the the calcification stuff. It didn't seem that long ago when people had these kind of issues and they had a very diminished quality of life, and it was all about kind of living in the process of dying from that.
All right.
And now it's like no. I mean, it's that's what I think is amazing and also I think, coming from a patient perspective, I know a lot of people they're scared about heart conditions, and they think I have a heart condition, and they think it automatically means I'm going to have open heart surgery and I'm going to be limited in what I can do, and what you all have talked about tonight is there's so many interventions that it's just amazing. But it gets back to too. It's still the leading cause of death in this country, and I'd love for you all to talk a little bit about kind of, I don't say preach, but talk to us about your perspective as someone who treats people with heart conditions and things that people can do, simple things that they can do to kind of avoid these issues, or if they have them, things that they can do to live healthy lives with these conditions.
Right. I think that's fundamental, right? These diseases are always co-managed between the physician and the patient. And I think it's fundamental for the patient also to understand the role, not only when they have the disease, but also on the prevention of the disease, right? So we know that elemental things like maintaining a healthy weight, maintaining an adequate diet, maintaining a good exercise regimen, be compliant with your medications when you're prescribed medications, stopping smoking, watching alcohol, keeping the diet and the weight controlled. I think that is tremendously impactful in the outcome of this disease. So it's very important for the patient to understand that no matter what intervention we do, how medicine advances, if you don't do your part, right, to co-management that disease with the physician, the outcome is not going to be optimal. So we really need to onboard patients to do their part. And sometimes here in West Texas it's difficult. We have cultural barriers, we have social barriers, we have different diet that people follow who are not particularly healthy. So it's very difficult to break those barriers. But I think with the patient collaboration, the outcome of this disease can be substantially improved, and the prevention of the disease can be substantially improved.
It's a good option. So talk to us about the cath lab team at Medical Center and the kind of role that they play in a successful program to bring these new procedures to West Texas, because I guess it's all about teamwork at the end of the day. You have talented physicians, but having a good cath lab team. Talk some about that.
Yeah, so these procedures require significantly more teamwork and coordination of care, both before the procedure, during the procedure, and after it, than almost anything that we do as cardiologists. We can put stents in. It's very simple. You kind of do it yourself, right? Like one person can do those kind of things. Those decisions are not always that complex. Sometimes they are, but not always. But when we do these particular type of procedures, there's so much gained and there's so much benefit from properly planning, properly mapping out exactly what you're going to do, that you prevent complications before you ever even touch the patient for the procedure. Right. And that is really a large amount of teamwork. We work closely with the radiologist, and actually in TAVR and Watchman and those two devices specifically, we work closely with the companies that make them. Because they are very good at they actually have a strong interest in good outcomes of their devices, and they're very instrumental in helping us map these things correctly and prepare to use the right device and the right size and whatnot. And so with these type of procedures, it really starts in the clinic. When the patients are referred to us, they're found to be, either have a symptomatic heart problem or problem with bleeding or whatnot, and they're sent to us. And when we evaluate them in clinic, we collect data from a number of points, functional status of their life and all these other things. And they're actually, I think there's several hundred data points that go into a national database for TAVR. And so those have to be collected before you even do the procedure. And then when we do the procedure, we do it with cardiologist and with a cardiovascular surgeon. And we're very lucky to have a great team member in Dr. Kirat Patel. He has been excellent. He has wanted to do this procedure for many years. I think he, probably more than anybody, knows that there are patients out here who have needed this for years. And sometimes you cannot avoid the risk of surgery for some patients, and they have to go through it. And he's taking care of these patients, so he knows. So he's a huge part of the team, and I think he's learned a lot and really been a tremendous contributing factor to why we have a successful program. And then the actual cath lab team itself has had to make big adjustments. They definitely have learned a lot of new stuff, I think, on the EP side. But stents have been put in, and we use kind of different finesse kind of tools for putting in stents, but that's been done for a couple of decades now. That's not like new per se. But they've been very good about adjusting to this and really taking care of this. This procedure is not always done in the cath lab. Sometimes some programs choose to do it in a surgery, in an OR room. But here we have a hybrid room that we're able to do it in. And so the cardiovascular surgery team, the team who actually does open heart surgeries here, works closely with us because they have to be ready to go. If we ever have a complication, they need to be able to get inside there and fix the problem as soon as possible.
Yeah.
And fortunately, we've not had to employ them yet. We work very hard to not use them.
Right.
But they're always there for us. And then afterwards, these patients go to the ICU, and then they see us in clinic. And so lots of people get exposure to these patients.
Right.
We tried to quantify this and figure out how many, and I think it's probably between 30 and 40 people have had to learn how to do these and learn some part of this role. And so it's a big team. It's not just me and the patient and the cath lab. It's a lot of people.
Right.
Yeah. I echo Dr. Farber's comments. I think these kind of procedure really require a village, and we have very fortunate that the hospital have been supported to take off the ground. I think they realize the importance of the community to have these services, and this is a multidisciplinary endeavor that involves physicians, also very importantly involve our anesthesia department. They are very important partners with us during this procedure. So now TAVRs have been done mainly with conscious sedation, so the patient is not even intubated. And Dr. Farber have been very successful with the anesthesia team to be able to do this procedure without general anesthesia. Also, we require helping with nursing. We have actually dedicated staff that are coordinators, and we have a fantastic coordinator for the structure of the program, Lisette, and she had done a phenomenal job as well coordinating this. I mean, in reality, it's a common effort, and really, it's a teamwork that results in a really good outcome for our community.
Good. So we're getting close to coming up on the magic bewitching 1 hour mark. And before we wrap up, I guess maybe some closing observations from each of you as to, obviously we're still, living and dealing with this pandemic. How has COVID had an impact on not only your patients as far as, infections and recoveries, things like that, but how has it had an impact on you as physicians and how you treat your heart patients day in and day out?
This is something that have not occurred just in the Permian Basin, so it affects us in a multiple layers, right? But something that we have seen nationwide is that patients have been very reluctant to come to the hospital because they have been very afraid, for example, of contracting COVID in the hospital. And what that had resulted is that, you know, a heart attack or a stroke are not diseases that you can sit on and wait. So not only here, but the American College of Cardiology and in general, the cardiologists through the nation has seen a significant decrease in the number of heart attacks, but not because they are not occurring, it's because people are not coming to the hospital timely. So, you know, we're trying to make sure that we educate the community to understand that it's true. We probably have about 400,000 or more people, very unfortunately, that have, you know, died from COVID, but we spend about, or we expect about 800,000 deaths every year from cardiovascular diseases, you know. So I think it's very important for people to understand that heart attack and stroke are emergencies during the pandemic, and they have to come to the hospital, you know, when the emergency occurs. So that's I think the first thing. And the second thing that have been affected us, right, is that, and this is common across the country, right, big chunks of the hospital have been taken to take care of the COVID patients. So that actually have delayed care for our regular patients. Like, for example, TAVR is a good example, right? We have been waiting because we don't have bed availability or ICU care availability. And this has happened throughout the nation, right? That multiple elective procedures or semi-elective or urgent procedures have had to put in hold because we don't, you know, the resources are devoted to COVID patients. So it really has been tremendously impactful in the cardiovascular services.
Yeah, I would mention that the other way that COVID has really affected us is in our clinics. A lot of people are doing telehealth visits or video visits through, you know, various media sources, but Dr. Bocalandro in particular does a very high volume of video visits, and this is going to be, I think, maybe not quite revolutionary, but it's going to introduce a new tool to really reach out and be able to communicate with patients and take care of problems in a efficient manner, because we've been forced to do this by wanting to reduce COVID. But now we realize, well, how effective can this be? This can be really effective. We just got to figure out how to use it well. And so, and our interactions with patients in the clinic is also very much different. We don't have family coming in like they did before. And so particularly for our older patients, trying to make complex medical decisions can be really tough when they're by themselves and don't have much confidence. You don't get to discuss it personally with the family. You know, a patient only is going to remember so many things when you say a million words to them. And so I think it really frustrates the families. I think it really frustrates the patients, and maybe hindering some of the medical decisions and really the understanding of the patients. And so there's a lot of frustration that we're trying to figure out how to adapt to, and a lot of communication difficulty.
Good point. Well, I think we need to wrap this up, but you know, I just want to say, and it underscores what we've talked about tonight. You know, when you live in a town, people don't know how fortunate they are to live in a community that has really first-rate hospitals and medical teams, medical community, until they've lived in one that doesn't. And I've known people, and I've known myself, lived in communities where you didn't have that. And y'all are just underscoring tonight how fortunate we are here in Odessa and West Texas, that we have, you know, the kind of hospitals and the kind of physicians such as y'all that are pushing this cutting edge technology. We had one person just ask, you know, if these advanced procedures are just in West Texas or spreading throughout the country. I think my response would be, well, actually, they're throughout the country, and we're really fortunate because we're getting these cutting-edge technologies and treatments here in West Texas because of doctors, physicians such as you, and being willing to do this. So I can't thank you all enough, not just for taking the time tonight to help us better understand these new procedures, but for what you do day in and day out. You know, y'all are pushing the envelope, and you're helping to roll out these technologies that are really changing lives. And I can't thank you enough. You know, Dr. Bocalandro, you've been here for, you know, so long, and appreciate you being a part of our community. And Dr. Farber, you know, the fact that you were raised here and you decided to come back here and make your career it really speaks volumes. So I want to thank you all very much. And Ravi is going to rejoin us. And I think with that, I'm going to shift it back to you, Ravi.
Thank you, Pat. Dr. Bocalandro, Dr. Farber, thank you very much for your time. And in these discussions, we have seen the community in West Texas, they really enjoy listening to your thoughts and ideas and how you like to share with them in this medium. So thank you for making time. And Pat, your thoughtful, deliberate, and questions are very much connects all the community members to these highly qualified experts. So we thank you for that, sir.
Well, thanks for making this all possible, Robbie.
Welcome, sir. Thank you very much for your time. Good night.